Most people over 60 believe that if their cholesterol is under control, their heart is protected. The number comes back acceptable. The doctor nods. The prescription is renewed. And the patient walks out feeling like the most important box has been checked. I have operated on people with perfectly normal cholesterol levels. I have stood over patients on an operating table. People who did everything right, who took their statin faithfully, who had annual blood tests that looked clean. And I have opened their chest and found arteries that were severely diseased. Not because the cholesterol number was wrong, but because cholesterol is not the whole story. It is not even close to the whole story. And here is what nobody in that 10-minute appointment has time to explain. After 60, there is a number that predicts cardiovascular events more accurately than total cholesterol, more accurately than LDL. A number that most seniors have never had measured. A number that does not appear on a standard lipid panel. A number that their doctor may not have mentioned once. That is the number I am going to talk about today. Stay with me. My name is Dr. Emmanuel Osei. I'm a cardiovascular surgeon with over 2 decades in the operating room. And today I'm going to show you which number matters more than cholesterol after 60, and exactly what to do about it. What you are about to learn could change the conversation you have at your next doctor's appointment. And it might be the most important number you have never been told to watch. Before I tell you what that number is, I need to give you a foundation. Because without understanding how cardiovascular disease actually develops, the number will not mean as much as it should. Here is what most people believe about heart disease. Cholesterol builds up in arteries. Too much cholesterol means blocked arteries. Lower the cholesterol and you lower the risk. That story is not wrong, but it is dangerously incomplete. Here is what the research has made increasingly clear over the past 2 decades. Cholesterol does not deposit in arteries randomly. It deposits in arteries that are already damaged. Arteries whose inner lining, the endothelium, has been compromised by inflammation. Arteries whose walls have been weakened by oxidative stress and chronic vascular injury. Think of it this way. A healthy artery wall is like a smooth, sealed surface. Cholesterol particles flow past it without issue. But when that lining is damaged, when there is chronic inflammation inside the vessel wall, it becomes sticky, rough, vulnerable. And cholesterol particles begin to embed themselves in those damaged areas. The real question is not how much cholesterol is in your blood. The real question is how inflamed and damaged your arterial walls are. And here is the number that tells you that, far more accurately than anything on a standard cholesterol panel. The number is called hs-CRP, high-sensitivity C-reactive protein. C-reactive protein is produced by your liver in response to inflammation anywhere in the body. The high-sensitivity version of the test can detect very low levels of chronic, systemic inflammation, the kind that does not cause obvious symptoms, the kind that does not feel like anything, but the kind that is silently damaging your arterial walls every single day. Let me be very specific about what the research says. A landmark study, the Jupiter trial, followed nearly 18,000 people with normal or low LDL cholesterol. People who by conventional metrics did not appear to be at elevated cardiovascular risk. The ones with elevated hs-CRP, even with perfectly controlled cholesterol, had dramatically higher rates of heart attack and stroke. Dramatically higher, despite the normal cholesterol. The study was stopped early because the evidence was so clear. Treating inflammation, even in people whose cholesterol looked fine, significantly reduced cardiovascular events. What this means for you is straightforward. You can have an LDL of 90, textbook acceptable, and still have an hs-CRP level that indicates your arterial walls are in a state of chronic inflammatory injury, which means cholesterol is actively depositing in those walls, which means plaques are forming and growing, and none of that will show up on a standard lipid panel. The hs-CRP test is inexpensive. It is widely available. It requires a simple blood draw, and it gives your doctor, and you, information that a cholesterol panel simply cannot provide. Now let me tell you about 5 specific things that drive hs-CRP higher in people over 60, silently, invisibly, every single day, and what to do about each one. This is the one that surprises people most. The bacteria responsible for periodontal disease, the infection that destroys the gum tissue and bone structure around your teeth, do not stay in your mouth. They enter your bloodstream directly through the inflamed gum tissue. They travel to arterial walls, and they trigger a local inflammatory response that is directly linked to plaque formation and instability. Studies have found periodontal bacteria in atherosclerotic plaques removed from coronary arteries. Not near the arteries, inside the plaques themselves. A significant proportion of adults over 60 have some degree of periodontal disease. Most of them have no symptoms beyond occasional bleeding gums or mild sensitivity. Most of them have no idea that what is happening in their mouth is connected to what is happening in their coronary arteries. Chronic low-grade urinary tract infections, common in older women, produce the same systemic inflammatory burden. So can unresolved sinus infections that have been present for months. Every chronic infection, no matter how low grade, is generating hs-CRP every day, year after year. See a periodontist, not just a general dentist, for a comprehensive periodontal evaluation if you have not had one in the past 2 years. If you have any chronic infection that has been treated briefly and recurred repeatedly, push your doctor for a definitive solution rather than another short course of antibiotics. And ask your doctor to measure your hs-CRP. Not all fat is the same, and this distinction matters enormously after 60. Subcutaneous fat, the fat under your skin that you can pinch, is largely metabolically inactive. It is not ideal in large amounts, but it does not drive systemic inflammation directly. Visceral fat, the fat that sits deep inside your abdominal cavity, wrapped around your liver, kidneys, and intestines, is metabolically active in a way that is genuinely dangerous. Visceral fat releases inflammatory compounds called cytokines continuously into your bloodstream. It produces interleukin-6. It produces tumor necrosis factor, and both of these directly stimulate your liver to produce C-reactive protein. Here is what makes visceral fat particularly insidious after 60. Body weight can stay exactly the same. The number on the scale does not move, while visceral fat increases significantly. Muscle mass decreases with age. That muscle is often replaced, pound for pound, with visceral fat. The scale says nothing changed. The inflammatory burden has doubled. This is why waist circumference is a far better predictor of cardiovascular risk in older adults than BMI or total body weight. A waist measurement above 40 inches in men or above 35 inches in women is a significant red flag, regardless of what the scale says. Measure your waist, not your hips, your waist, at the level of your navel. Write it down, bring it to your next appointment, and ask your doctor about hs-CRP alongside it. The two together tell a story that weight alone never can. The most effective interventions for visceral fat specifically are resistance training, reducing refined carbohydrate intake, and improving sleep quality. All three work through the same mechanism, improving insulin sensitivity, which directly reduces visceral fat accumulation. Here is something that standard lipid panels do not measure, and should. Not all LDL particles are equally dangerous. The critical variable is whether LDL has been oxidized. When LDL particles circulate in an environment of high oxidative stress, driven by smoking, poor diet, chronic inflammation, high blood sugar, they become chemically modified, oxidized. Oxidized LDL is not recognized normally by the body's clearance systems. Instead of being processed and removed, it is engulfed by immune cells in the arterial wall. Those immune cells become engorged and die, forming the core of an atherosclerotic plaque. Normal LDL, even at moderately elevated levels, does not behave this way. And here is the clinical implication. Two people with identical LDL readings can have completely different cardiovascular risk profiles, depending on what fraction of their LDL is oxidized. The person with high oxidative stress has far more dangerous cholesterol than the raw number suggests. What drives LDL oxidation? Smoking, directly and significantly. High blood sugar and insulin resistance. The glucose attaches to LDL particles and makes them more susceptible to oxidation. Refined seed oils high in omega-6, canola, soybean, sunflower, which oxidize readily at body temperature and introduce oxidized lipid products directly into the circulation. And low antioxidant intake, particularly low levels of vitamin E, vitamin C, and polyphenols from vegetables and fruits. Ask your doctor about an oxidized LDL test. It is available, though not yet routine. In the meantime, address the drivers directly. Eliminate seed oils from your cooking. Increase antioxidant-rich foods, berries, dark leafy greens, olive oil. Control blood sugar. And if you smoke, there is no single more powerful cardiovascular intervention than stopping. Sleep is when your cardiovascular system repairs itself. That is not a metaphor. It is the literal biological function of sleep from a cardiovascular standpoint. During deep, slow-wave sleep, blood pressure drops. Inflammatory cytokines are cleared. Endothelial cells regenerate. The immune system performs maintenance on arterial walls. When sleep is chronically inadequate, under 7 hours in most adults, under 6 hours in older adults, that repair process is interrupted. Night after night. The inflammatory burden accumulates without adequate resolution. Multiple large studies have found that consistently sleeping fewer than 6 hours per night is associated with hs-CRP levels that are significantly elevated compared to those sleeping 7 to 8 hours. The relationship is dose-dependent. The less sleep, the higher the inflammation. And here is the compounding factor after 60. Sleep architecture changes with age. Deep, slow-wave sleep, the most restorative phase, decreases substantially. The total hours in bed may look adequate, but the biological quality of that sleep is reduced. Sleep apnea, which disrupts sleep architecture profoundly, independently elevates hs-CRP through repeated cycles of oxygen deprivation and stress hormone release. Every apnea episode generates an inflammatory response. Multiply that by dozens of episodes per night, hundreds of nights per year, and the cumulative inflammatory burden is substantial. 7 to 8 hours is the target. Not time in bed, time actually sleeping. If you are consistently below that, or if you wake unrefreshed despite adequate hours, discuss a sleep evaluation with your doctor. Treating sleep apnea, documented in multiple studies, reduces hs-CRP levels measurably within weeks of starting CPAP therapy. The connection between chronic stress and cardiovascular disease is not soft science or wellness language. It is hard mechanistic biology. Chronic psychological stress, the kind that does not resolve, the kind that runs as a background current through weeks and months and years, produces sustained elevation of cortisol and adrenaline. Cortisol at chronically elevated levels does 3 specific things to your cardiovascular system. First, it directly raises blood pressure, consistently, chronically, without the obvious spikes you might notice. Second, it promotes visceral fat deposition, because visceral fat tissue has high concentrations of cortisol receptors and actively accumulates fat in response to cortisol signaling. Third, and most relevant here, it upregulates inflammatory pathways throughout the body. Cortisol is designed to be a short-term anti-inflammatory agent in acute situations. In chronic elevation, that system inverts. It becomes pro-inflammatory. The result is sustained hs-CRP elevation driven directly by psychological state. I want to say something clearly about this, because I see patients dismiss it. Telling a patient to reduce stress is not the same as acknowledging that stress is a real, measurable, biological driver of cardiovascular disease. It is. The research is not ambiguous. Chronic psychological stress elevates hs-CRP, accelerates atherosclerosis, and raises cardiovascular event rates independently of every other risk factor. Structured interventions, specifically mindfulness-based stress reduction, which has been studied rigorously, have been shown to reduce hs-CRP levels in older adults with cardiovascular risk. Not by a trivial amount, by clinically meaningful amounts. If there is chronic, unresolved psychological stress in your life, a relationship, a loss, a situation that has been generating sustained distress for months, that is not separate from your cardiovascular health. It is part of it. Address it directly. Consider structured stress reduction. Consider speaking with someone. Not because it will make you feel better, though it will, because it will reduce the inflammation that is damaging your arterial walls. I want to tell you about a man I'll call George, 66 years old, retired police officer, built like someone who had been physically active his whole life. He came to me after experiencing chest tightness during exertion. Nothing dramatic, just an uncomfortable pressure that came on when he climbed stairs or walked quickly uphill. His primary care doctor had run a full lipid panel 6 months earlier. Total cholesterol, 178, LDL, 94, HDL, 52, triglycerides, 130. Every number in the acceptable range. His doctor had told him his cholesterol was excellent, but something about his symptoms bothered me. I asked about his sleep. Disrupted. He had always been a light sleeper, and it had gotten worse since he retired. I asked about stress. His wife had been ill for 2 years with a serious chronic condition. He was her primary caregiver. He downplayed it, the way men of his generation often do, but it was clearly taking a significant toll. And I looked at his gums during our conversation, visibly inflamed. He had not been to a dentist in 3 years. I ordered an hs-CRP alongside a cardiac stress test. The hs-CRP came back at 4.2 milligrams per liter, high risk range. In a man whose cholesterol was textbook perfect, The stress test showed significant ischemia, reduced blood flow to the heart muscle during exertion. He went to the catheterization lab. 2 coronary arteries were significantly narrowed. He required stenting. Afterward, when we reviewed everything together, George said something I think about often. He said, "My cholesterol was fine. Every doctor told me my cholesterol was fine. Nobody ever mentioned inflammation. Nobody ever mentioned that number." He had the right number on the wrong test for 6 years. We addressed the inflammation. The periodontist treated his gum disease. He started a structured sleep program. He and his wife got support from a caregiver support service. His hs-CRP dropped to 0.8 within 8 months. George is doing well. But he should have had that conversation years earlier. I want to say something directly. The medical system is not withholding this information from you deliberately. Physicians are working under real constraints, time, reimbursement structures, guidelines that take years to incorporate new evidence. The standard lipid panel became the default cardiovascular screening tool in the 1980s. Medicine moves slowly, but you do not have to wait for the system to catch up. You can walk into your next appointment and ask for an hs-CRP test by name. You can ask, "What is my level of systemic inflammation?" You can ask, "Are we looking at my cardiovascular risk completely, or just through the lens of cholesterol?" Those questions cost nothing. The test costs almost nothing. And the information it provides could change the entire trajectory of how your cardiovascular health is managed. Total cholesterol is a useful number. LDL is a useful number, but they are incomplete. They tell you how much cholesterol is circulating. They do not tell you whether your arterial walls are in a state of active inflammatory injury. hs-CRP tells you that. After 60, when arterial stiffness is already present, when the margin for error is smaller, when the consequences of undetected disease are more severe, you deserve the most complete picture available. Go get it. Let me bring this together clearly. 1. The number that matters more than cholesterol after 60 is hs-CRP, high-sensitivity C-reactive protein. It measures systemic inflammation, the real driver of arterial plaque formation and cardiovascular events. Ask your doctor for this test by name at your next appointment. 2. Chronic dental disease is a direct source of arterial inflammation. See a periodontist. Treat your gum disease. It is not cosmetic. It is cardiovascular medicine. 3. Visceral fat, the fat around your organs, drives hs-CRP continuously through inflammatory cytokine release. Measure your waist. Resistance training, reduced refined carbohydrates, and better sleep are the 3 most effective interventions specifically for visceral fat. 4. Oxidized LDL, not total LDL, is the dangerous form. Eliminate seed oils, increase antioxidants, control blood sugar. The type of cholesterol matters more than the amount. 5. Poor sleep elevates hs-CRP measurably and consistently. 7 to 8 hours of quality sleep is cardiovascular medicine. Treat sleep apnea if present. It reduces inflammation within weeks. 6. Chronic psychological stress is a biological driver of arterial inflammation, not a soft factor, not a lifestyle consideration. Address it directly. Structured stress reduction produces measurable reductions in hs-CRP in older adults. Here is what I want you to do this week. Ask your doctor for an hs-CRP test. 4 words. That is all it takes to start getting the complete picture of your cardiovascular risk. I want to hear from you. Have you ever had an hs-CRP test? Has your doctor ever mentioned inflammation as a cardiovascular risk factor? Or has every conversation been about cholesterol? Tell me in the comments. I read every single one. And your answer might help someone else in this community realize that there is a number they have never been told to watch. If this video gave you something important, please share it. Not for me, for someone in your life who checks their cholesterol every year, gets a reassuring number, and has no idea that inflammation is the part of the story they are not being told. Send this to them. It could change everything. Everything I've shared today is based on current cardiovascular research and my clinical experience as a cardiovascular surgeon. This is general information, not personal medical advice. Always consult your own doctor before making any decisions about your health, including requesting new tests or making changes to your treatment. Take care of your heart. It has been working for you every single minute of your life, without ever asking for anything in return.